I'm here at ICS with the state-of-the-art lecturer, Scott Hultgren, and he's going to give us a quick summary of his lecture this morning.
Sure. So we've been interested in trying to understand the molecular basis of the molecular crosstalk that occurs at the host pathogen interface between E. coli and the bladder epithelium. And by understanding those details, we're interested in trying to come up with new therapeutics that could block those interactions and therefore serve as antibiotic-sparing reagents. And in particular, it's been known for decades clinically that a history of UTI predisposes individuals to recurrent UTI. But the molecular basis of that has been completely unknown. And so we've been trying to understand the mechanism of how history predisposes to recurrence. And long story short, we've elucidated that a urinary tract infection with E. coli leaves a molecular imprint on the bladder mucosa. And that imprint predisposes to increased likelihood of recurrence upon exposure to uropathogenic E. coli. And so by understanding this pathway, we're trying to create sort of a molecular blueprint. And by understanding that blueprint, find nodes that we can develop compounds to interrupt the pathogenesis, develop antivirulence compounds.
So about the antivirulence compounds, I know that you're working on a couple. Is there any one in particular that you're very particularly excited about?
Yeah, that's a good question. So with E. coli, we've discovered that they produce these hair-like fibers known as pili, and at the tips of those fibers is an adhesin, and that adhesin recognizes sugars, in particular mannose, that decorates the surface of the bladder with stereochemical specificity. And that recognition event is critical for the ability of the bacteria to gain a foothold on the bladder surface, colonize, invade, and cause disease. So we're developing compounds that bind to that adhesin at the tip of the pilus with 1,000,000-fold more potency than the natural receptor. And those compounds we've shown to be efficacious in mouse models to inhibit colonization and also to cure an infection when delivered orally within 6 hours of oral delivery. So we're really excited about potentially moving that into the clinic.
And I know from your talk this morning, you were also looking at enterococcus and indwelling catheters, and you noticed that fibrinogen was deposited in the catheters. Can you tell me first of all, how the fibrinogen is getting there? And second of all, is there any way that you could prevent that buildup inside the catheters?
Another great question. So it's actually a paradox. So it's known whenever you insert a foreign body in the human body, inevitably it'll get infected. Inevitably biofilms will form on it. And paradoxically, enterococcus, catheter-associated urinary tract infection is a very important problem, but people have been studying this in the lab for years, and they can't get enterococcus to form biofilms on these catheters. So we resolved that paradox by showing that whenever you catheterize a host or even a human, it causes an inflammatory response that results in the release of fibrinogen, and then fibrinogen coats the catheter. And then enterococcus elaborates an adhesin that binds to the fibrinogen. And so the mechanism by which enterococcus forms a biofilm on these catheters is by binding to the fibrinogen that coats the catheter, and that actually eats the fibrinogen, so it's dinner and a movie for the bugs. And so then by understanding the mechanism by which enterococcus interacts with the fibrinogen, we've developed a vaccine that protects against that interaction. So we're excited about moving that forward as well.
I have a question by a tweet. It's from Dominica Bios. Are vaccines an option for UTI treatment and prevention?
So the question is, are vaccines an option? I think they're a great option. So there's one vaccine right now, I know, that's related to technology that we've produced that's in phase 1 clinical trials. And it's based on that adhesin at the tip of the pilus. So you vaccinate with that adhesin, antibodies build up, by binding to that adhesin at the tip of the pilus, block colonization as well as opsonize the bacteria for clearance. So we're excited about that. Other people are developing vaccines against various other antigens that uropathogenic E. coli produce, like iron scavenging proteins and so forth. And I know another company is working on using O polysaccharides as a vaccine. So I think there's a growing interest in developing a vaccine, an antibiotic-sparing therapy.
So another question from the same individual is, are bacteriophage a viable option for treating urinary tract infections?
Whether bacteriophage are a viable option, I think to be a viable option, one would want to target the reservoirs of phage. So, for example, the gut microbiota. If one could eliminate the reservoir, then one could prevent the episodes of recurrence. So I think with bacteriophage, probably the best idea would be targeting the reservoir.
So you heard today from some of the people in my group that there are, in fact, resident bacteria in the bladder, the female urinary microbiota. Could you put your work in the context of the fact that the bladder is now known not to be sterile? And how would that interact with an invader like uropathogenic E. coli?
Well, as you know, I'm a big fan of your work, and I think you've made some tremendous strides forward in elucidating this brand new, surprising phenomenon. And I think everyone who are investigating this field now need to take this into account and reinterpret their data and think about things differently. As you know, in the gut, there's a phenomenon known as colonization resistance. And so it's very difficult for an invading microorganism to colonize the gut because of this phenomenon. So one would begin to ask, is that same thing going on in the bladder? And is your microbiome that you've discovered protecting against invaders? And do dysbiotic changes in the microbiota then allow that invader to get in and cause disease? So I think there's a million fascinating questions that your work has opened up, and I'll be very excited to read your papers as we move forward.